Welcome to the University of Toronto's Joint Centre for Bioethics seminar series for the 2022-2023 academic year. I'm Rashad Raymond, a PhD student in the Department of Philosophy and Joint Centre for Bioethics at the University of Toronto, and it's my pleasure to be moderating today's seminar. Today's speakers are Alyssa, Izatt, Rebecca, Greenberg, and Nipa, Chauhan, and they will be presenting on their talk entitled Ethical Considerations for Sterilization Refusal in Nulliparous Women. The format of today's seminar is a presentation by our speakers, followed by a moderated discussion with the audience. The seminar is being recorded and will be posted on the Joint Centre for Bioethics website, where you can also find archived seminars. Before I introduce today's speakers, the Joint Centre for Bioethics wishes to acknowledge this land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still the home to many Indigenous people from across Turtle Island, and the JCB is grateful to have the opportunity to work on this land. Now it is my pleasure to introduce today's speakers. Alyssa Izatt is a PhD student at the University of British Columbia in the Department of Philosophy and W. Maurice Young Center for Applied Ethics. In her research, she focuses on reproductive ethics, especially reproductive autonomy and justice, and family ethics. Dr. Rebecca Greenberg is an associate professor in the Department of Pediatrics at the Faculty of Medicine. She is also a bioethicist member of the Joint Centre for Bioethics at the University of Toronto. She is a member of the bioethics committees for the Canadian Pediatric Society and the Society of Obstetrics and Gynecology of Canada. Her main research interests include moral distress, moral resilience, ethics education, and priority setting. She is the recipient of a number of research grants, including a recent operating grant from the Canadian Institute of Health Research pertaining to moral distress and resiliency. Nipa Chauhan is the bioethics associate at Sinai Health. Nipa is the founder and editor-in-chief at Cafe Bioethics, a popular bioethics literacy initiative. Nipa is on the board of directors for various organizations and committees such as Misinformed, Conceivable Dreams, and the CFAS. Maybe it's called CFAS. Her main research interests include reproductive autonomy, emerging reproductive technologies, and fertility law regulation. Alyssa, Rebecca, and Nipa, welcome, and we look forward to your presentation.
Thank you so much, Rashad, for that introduction, and thank you to the JCB for having us. It's great to be among the JCB crowd again. Just as Rashad said, we're going to be discussing ethical considerations for sterilization refusal in nulliparous women. And I want to thank my fellow authors who are with me today, Alyssa and Rebecca. And of course, we have to acknowledge Dr. Julie Thorne and Joanna Erdman, who were fundamental to this paper. Their expertise and their time and energy, we're so grateful for it. So just getting started, it's, again, like I said, it's great to be back in the JCB crowd. I did my master's at the JCB a few years ago, and if you were one of the professors in the program, you know that I couldn't stop talking about sterilization refusal in childless women under 30. A lot of my papers had to do with this topic, and so I'm especially grateful to Alyssa and Becky for really helping take this on and lead this paper. I'm really excited to share this paper with you. So first we'll get started. There's no conflicts of interest to declare. And our objectives for today are, one, to discuss the clinical, ethical, and professional considerations relating to tubal sterilization requests in young childless women. Then, of course, we're going to explore the limitations of decisional regret. And our third objective for today is to provide considerations for practice for physicians. So we found that physicians are really the pivot point in this issue, and to make the most helpful paper as possible, we decided that we should provide those practical considerations. So we're going to get to that near the end. But to start, we just want to talk about, just to set up context for a second, what permanent contraception actually is, what we mean by tubal sterilization, and what those clinical considerations are. So first, it's a medically unnecessary elective contraceptive surgery. It is an invasive surgery. It's performed by an OB-GYN with surgical expertise. It is treated as a permanent procedure in contrast to vasectomies for males. Subsequent pregnancy may be possible via in vitro fertilization or through a reversal. So you might be thinking, okay, she just said this is a permanent procedure, but reversals are possible. I'll get into that now. So there's a few different types to do a tubal sterilization. You could get the fallopian tubes banded, they can be cauterized, they can be tied and cut or clipped. In those instances, reversal is somehow possible, but it's still treated as permanent because pregnancy after that is very, the likelihood of that is very, very slim. Lately, sterilizations have been occurring by actually removing the fallopian tubes completely. And so if the fallopian tubes aren't even there anymore, pregnancy is not possible, so reversal isn't possible. So that's just some clinical background for permanent contraception. And we think it's important to acknowledge that reproductive control in Canada really does have a dark history. So it's important to acknowledge that there have been many women in Canada's history, Indigenous women, women of color, who have been sterilized involuntarily, who did not want to be sterilized, and they were sterilized involuntarily. Our issue today does have a lot to do with reproductive control, but it has more to do with women who would like to be sterilized, who voluntarily would like to be sterilized, but are not able to access that procedure due to various things that we're going to discuss. So just think it's important to acknowledge this, but our issue is adjacent and still has much to do with reproductive control. So now I'm going to show you this clip from City News. I'm going to make sure my sound is being shared as well. So share sound. And the thing with this clip, I saw this clip from City News. I think I was really just watching CP24, like randomly January of 2018. And I came across this story and I thought it was so entrenched with bioethics and bioethics principles. And it was just very fascinating. So I'll stop talking and I'm going to show you the clip. Hopefully you can hear it.
I don't want any children. I've never wanted kids, even when I was a young little girl. And she's always said, oh, wait. And then last year I went up and I asked her and she blatantly told me, oh, what if you meet the man of your dreams and he wants kids? There's no safety reasons. It's just her personal opinion.
So there's a lot to unpack there, right? Two things really were apparent to me, that were really glaring to me. So the first thing is this woman reports that her physician asked her, what if you meet the man of your dreams? And that question was ringing in my ear. It has been ringing in my ear these past few years. What if you meet the man of your dreams? The thought that a physician can ask a patient that, what sort of context is behind that question, right? And then the second thing that was glaring to me from what she said was, she said that it has nothing to do with safety, it's just her personal opinion. So there's a lot to unpack there, and you could see how the physician is really at the crux of this matter. And so that got us really started down a rabbit hole. Ooh. So for the next slide, in our research, once you go down the rabbit hole, you realize that many women have been writing about this for a really long time around the world as well. So in Canada, for sure, it's been written about, but also in the UK, there was a court case that was very, very interesting. And recently, with the overturning of Roe v. Wade, this issue has seen a resurgence. It's a bit of an insidious issue, right? Because with Roe v. Wade being overturned, a lot of women down in the US wanted birth control that doesn't expire. So that includes permanent contraception or tubal sterilization. And again, I've said this before, but we really think the physician is at the crux of this matter. So especially here in Canada, there's no law against someone getting sterilized in their 20s or somebody who's childless. And most of the organizational structures, like the Society of Obstetricians and Gynecologists of Canada, which we will go into, they also give the thumbs up as long as someone is giving informed consent. So we really wanted to explore the hesitation on the part of the physician and explore their duty, their fiduciary duty to the patient, but also how it can come into conflict with their conscience. So we found that the position of the doctor is really important here. And to set up the discussion a little bit more, we're just going to go into the reasons for the refusal that women experience. So historically, elective tubal sterilization has been difficult to access. So I should say that these days, it's probably the most accessible it has ever been, which is not quite saying much because it's really still difficult to access. But back in the day, decades ago, there was something called the 120 rule. So what that is sort of like a metric used by physicians to figure that sterilization shouldn't even be considered unless a woman's age multiplied by the amount of children she has exceeds 120. So if we think about, for example, someone who's 30 years old and she has 3 kids, her number would come up to 90. And so that's not even close to 120. Sterilization couldn't be considered for her. So that's something, fortunately, that's not a thing anymore in 2022, but that's something that was quite prevalent back in the day. Also, spousal consent. Husbands would have to give consent to the procedure as well. So that, fortunately, is not the case anymore here in Canada. But these days, the physician reluctance to restrict reproductive potential it's because of the clinical need of it. So that reluctance has a lot to do with not wanting to restrict that reproductive potential down the line, especially without the clinical need. It's an elective surgery, it's medically unnecessary, and it's an invasive procedure, it's a surgery. The availability of less invasive and temporary alternatives are there. So there are many different options if you don't want to do something permanent. So that's what would be offered first by a physician in case a sterilization is requested, something like an IUD or birth control, things like that. And there is potential for regret post-procedure. So that's one of the things that we want to dive deep into. Regret post-procedure, it feels ambiguous. You know, there are hardly any parameters to what we define regret as. And yet there is some literature out there that Alyssa is going to go into. So on that note, I'm going to hand it over to Alyssa, and the floor is yours. Go ahead.
All right, great. Thank you so much, Nipa. I think you've provided a really wonderful overview of the issue we're tackling and the social circumstances that exist today when we're talking about access to permanent contraception, when it comes to women's access of permanent contraception. So I think the most important thing to highlight here is the role that, or one of the most important things to highlight here is the role that regret is playing in decision-making. And I think this is a very, philosophically rich topic that I'm excited to get into with today. Oh, sorry, just trying to click. Okay, there we go. So when we're talking about regret, there have been a lot of studies about regret, and especially the regret incidence when it comes to sterilization care. So the first one that comes up is this CREST study. So this was done in 1999. It's a collaborative review of elective sterilization. So this followed patients who had had the procedure previous to 99. And what it showed is that the cumulative rate of regret when it comes to sterilization is around 12.7%. But for the demographic of patients who are under 30 when they were sterilized, the rate is 20%. So that's quite a big difference in the incidence of regret. And this has also been corroborated by subsequent studies that the incidence of regret is higher for patients who receive the procedure when they are under 30. And there's also some other research that goes along these lines. So for instance, the rate of reversal has been documented at around 1% for people who have tubal sterilization, while it's around 4% for women who access it when they're under 30. So again, about 4 times as many women go back and get this reversed. And so there is this discrepancy. And there are also, which we'll get into, this association of reversal regret with depressive symptoms. So patients who regret their procedure, there's this incidence, this correlation with depressive symptoms afterwards. And so obviously this is something we need to be aware of and I think interpreting the ethical importance, is what we're aiming to do. And what I want to highlight from this discussion is it's not clear whether regret is considered clinically harmful or not. So is this something that physicians should be striving to help their patients mitigate? What is the role of regret in the clinical context? This is not really clear just based on like general rules for practice, for instance. And so it's useful to explore like the role that it is playing, but also what role we think it should be playing. All right, so this is the study we mentioned that correlates tubal sterilization with regret and with depressive symptoms. So one thing that's interesting to highlight for this, and that would certainly be useful in a patient counseling context, for instance, is that those who underwent sterilizations for reasons aside from not wanting children tended to regret the procedure more. So this could be for financial reasons, or maybe spousal encouragement to access sterilization. So these reasons tend to be, related to higher rates of regret. And what's interesting is when we're just talking about this demographic of child-free women, for instance, who are very strong in their position about not wanting children, about that not aligning with their values, I think that's useful to keep in mind. And it also seems salient for the importance or the risk of regret in terms of the importance of a patient's values. And then it's also important because this is useful interpreting ways in which regret could potentially impede patient well-being because of the association with depressive factors. So as Nipa has really wonderfully highlighted, there's a lot of factors to do with the patient experience. So as we can see from this public, just like in terms of what news articles have been written about this issue, there seems to be this outcry of women saying that they want to access sterilization and that they're not able to. So this is what is sort of in popular media, for instance, and I think it's useful to explore how this looks in clinical practice. So we'll touch on this. It's not like there's great demographic research about people who go in, request sterilization, and then are subsequently denied, but there has been qualitative research done on the topic. So one thing that this qualitative research, I'm referring to one study that was done by Carween New and Dustin Kostescu in 2021 about access of permanent contraception with patients, is that they reported going in with really well-considered requests for sterilization, but they were still denied by their physician due to reasons of age or parity. So they're too young, they don't have kids yet, and so their requests were refused. And then I think this is important to highlight how they process this feeling of rejection from their physician. And so oftentimes patients felt belittled afterwards, or that their motivation was not taken seriously enough, or that they weren't taken seriously in their request, that this is the sort of thing that could just be brushed off and like come talk about it 5 years later, for instance. So in that case, it seems to be that these patients have these really strongly held values that are not being factored into decision-making necessarily. And so that's useful to highlight because it is relevant to the patient-physician relationship, right? And it's useful to consider as we go forward the role that patient counseling about contraception, as well as the patient-physician relationship, how this is affected by refusals, or even just how refusals are handled. So, obviously we think it's very important to preserve the physician-patient relationship and to move towards patient-centered care in these cases. And we think that an understanding of diverse values, as well as an accommodation of diverse values, can be helpful in accomplishing this. And this is what I think that some of the data and some of the experiences of women what they've gone through, I think that that's what this points towards, that they have these values that are not necessarily understood, but that are important for their medical decision-making and that need to be considered. Right. Okay, so next I want to talk about what we think of when we're thinking about harm and regret. So that was one of the questions I posed earlier, is regret clinically harmful? Can this be considered a harm to the patient in terms of, like non-maleficence, like a duty of non-maleficence, for instance? And I think it's useful of considering maybe like pushing a little bit on what we're thinking of when we're thinking about ways in which regret might harm a patient, right? So when we're just thinking about how does regret harm, for instance, I think maybe the most straightforward option is that it's an emotional harm to the patient, right? So it's this affective state that we want patients not to experience. If it's possible to avoid it, we should avoid it, right? Because it's better to have a patient not experiencing this emotional harm than if they go through with the sterilization and go on to regret it. So that's a pretty straightforward interpretation, but there's also the potential to think in terms of the limitation of future options. So in this case, a patient her reproductive choice in the future is limited because she no longer has the option as straightforwardly to have children, to have biological children if she wants. And so in this case, if we're taking emotional harm or the limitation of future options to be harmful, in that case, it seems like a temporary contraception is the best option for a patient. It's the one that reduces harm to the greatest extent. And so then we should consider regret to be harm in this way. I don't think that it's clear that regret is harm in this way, that it is emotionally harmful. And there's also questions to be said about balancing the limitations of future options with present autonomy, which is what I'll get into later. But I think the important thing to contrast is that even if we consider regret to be harmful in some ways, seeking to prevent regret in the sterilization case does not preclude harm. So there's other ways in which a patient can be harmed if she's denied her request for a sterilization, right? So there is the risk of unwanted pregnancy. There's the delegitimization of her values and goals, which we talked about on the previous slide. And there's also this limitation of reproductive autonomy. And so this is important because limitations on reproductive autonomy should always be well justified. So we should have this like a really substantive idea of the way in which regret harms to justify this. And there are also ways in which we might consider that the refusing a patient's request can be harmful in a different way. So in terms of the options under the green header, we can see that these are all ways in which a patient might be harmed, but that she wasn't able to prevent this harm from happening, right? So she sought out contraception because she didn't want to be pregnant, because she had these values and goals, and it's something that she wasn't able to do for herself. Whereas on the contrary, if she goes on and experiences regret, at least this is on her own terms, and it's more reflective of her autonomy and her values and her choices, which is generally how we would think of the role of autonomy more broadly. So I think it's just useful to reconceptualize the way in which we think regret might harm. I think there's some limitations there. But it's also clear that if we're just concerned about harm reduction, that refusing sterilization is not necessarily the best way to do that. Okay, so next I want to get more into the limitations of regret. So I think there's a lot to be said here. So first, I'll touch on the ways in which regret can be socially constructed. So when we're thinking about like the occurrence of regret or which decisions tend to be regretted more, one sociologist, Diane Lalonde, has done some nice research on this, and she talks about the social construction of regret. So in this case, there tends to be choices which seem to be more up for criticism or more subject to scrutiny. And so in that case, they're regretted more, right? So there's this idea of sterilization being a somewhat controversial decision, not something everyone would decide for themselves. And so in that case, it's more up for grabs in terms of how we might criticize it or reflect on it down the line, right? So you might think of someone who is sterilized at 25, and every time she goes home for Christmas, her family members ask her, "Are you regretful of this decision? Do you think you made the wrong decision?" And so this focus on this one choice can lead to a higher occurrence of regret because there's a greater focus on regret. And I think we can see this in the research where the occurrence of regret on sterilization has been very well documented. It's been well studied. And so in some case, there's this idea that we're concerned about regret here. Well, we might not necessarily be focused or looking at it in other ways. Like, for instance, we don't ask people who are accessing IVF, for instance, if they're worried about like regretting having children. It's just not something that we look for in that context. There's also some ideas about compulsory maternity that contribute to the construction of regret, as well as the value of femininity. So there's this way in which femininity is associated with motherhood. And so the rejection of motherhood is sort of this rejection of this traditional feminine role. And then it's more, it goes further against maybe social norms and social expectations. And so there's ways in which that also contributes to regret because it's going against what is expected of a person. And so in that case, it might be, at least I would argue that it seems to be the case that that's not necessarily the thing that is best handled in a clinical context, because this occurrence of regret can be so impacted by factors that are just totally outside of the clinical realm. So for instance, like social pressure or social norms can contribute to this. There's also this unequal consideration of regret in comparable cases. So we don't have as much data, for instance, on the incidence of regret with vasectomies. Some of the regret literature that does exist is about couple regret rather than just the person who's had the procedure. And so in this case, we see that there's a sort of unequal consideration or unequal focus in the literature. And what I think is interesting is when we're thinking of this as regret as the only harm, so consideration of regret as a harm or as the only harm, it seems to be playing a pretty significant role when we can see that there are all these other factors that might be going on that don't necessarily have anything to do with how good of a choice a sterilization might be. And so what we want to highlight here, I think what is the most important discussion of the regret, of our regret analysis, is that decisions that are voluntary can be regretted. So a patient can go in and be counseled about all of the reasons why she might regret her sterilization, or that it's possible that she could regret her sterilization. She might be fully informed about other risks, like surgical risks, for instance, with sterilization. And she might still think that it's the best decision for her at the time. She might have her sterilization, and then 10 years down the line, she might regret it. But in this case, it's a choice that was fully voluntary and fully informed. And so in that case, it seems that we're going a bit beyond of what we typically expect of patients. It seems that it's also asking a lot of doctors to ensure that their patients don't regret decisions, because these decisions that are voluntary and informed, they might be good decisions at the time, and there are other reasons why they might be regretted. And so in that case, it seems like it's not necessarily the most important thing to focus on when we're talking about counseling a patient about sterilization, right? Because there's so much that goes into making regret, and there's so much, there's only so much we can do in terms of counseling a person to prevent their regret. And so it just doesn't seem like the best thing to make our decisions around. And, it's also useful to highlight that these women are competent in other areas of their lives. They can make decisions that they regret in other ways. And we don't necessarily think that this is a call for intervention in those regards. And so in that case, we can see that this is perhaps a bit of a discrepancy, and perhaps a bit of too much focus on regret, because sometimes autonomous choice just does lead to regretful decisions. This is just part of making decisions, and that this is not something that we always think justifies intervention. And I would argue it shouldn't justify intervention. And so the main takeaway is that prioritizing regret in refusals just means that certain women are disqualified from decision-making in this area. And it's important to consider regret because it does constitute a risk of the procedure, but it seems to be that we might be losing sight of more important things, such as the quality of consent, the level of information that a patient has. All right, so next I'll touch on reproductive autonomy. So I think it's helpful to go into a bit further why a patient might want to be sterilized, and why we might think then that a temporary contraception is not enough, and why sterilization in this case is really the best option in terms of honoring a patient's goals and values. So oftentimes what we've seen with patients, what they're expressing, for instance, in like public, we can think of the video that Nipa played at the beginning. So in this case of this woman having a very strong child-free value, it's more so a value that she has for her life overall. It's a goal she has. And so in that case, it seems that a temporary measure is not enough because the desire for sterilization relates to this desire for autonomy over a patient's life and body. And it's sort of this deliberate desire to align her body with her values. And so in that case, we can see that temporary contraception is not enough. And it's not adequate in addressing all of the values and goals that play into the decision to become sterilized. And there's also an important role or important contribution that it would play to a patient's welfare and her sense of bodily autonomy, that she could go into her physician or her practitioner and say, this is what I think is the best choice for me. This is the goal I have. This is what I see my life being. And this is why I think it's important in accomplishing that. And then to have that choice respected, that's really important for the sense of bodily autonomy and control over one's own life. And so, I guess the main thing to highlight when we're talking about reproductive autonomy is that it's not just a form of contraception. And so it's assisting these women in leading their lives in accordance with their values. There's also some comparisons to be drawn with other things that we might think are risky or potentially regrettable, but that we don't think regret is an absolute barrier to access. So for instance, thinking about Canada specifically, there is a very big conversation about regret in the context of trans care, for instance, or gender affirming procedures. And so that is something that's discussed a lot, but at least in Canada, it's not taken as this absolute barrier to access a certain intervention. And we can see that there are other things beyond regret that are more important to consider, such as a patient's autonomy and their welfare overall. There's also an analogy to be drawn with cosmetic surgery, for instance, which, many young women do access different cosmetic procedures, and there is a risk of regret there. And it also oftentimes is a permanent procedure. But we still think that the ability to make choices about one's own body are more important than the risk of regret. And we value autonomy in those realms. And we're making an analogy here that it should be similar when we're thinking about sterilization and reproduction, especially when we think about how central reproduction is in realizing other goals and freedoms in a woman's life. All right, so next, also just a quick note about reproductive equity. It's useful to consider what threshold of consent we're establishing here. So the main takeaway I would say here is that there might be too much that's being asked of patients. When a patient comes in with a well-considered request, when she's well-informed about the procedure, if she's still not able to access or she's still denied this procedure, it seems that we might be asking too much in terms of consent, and that we can oftentimes consent to things that we know we might regret eventually. There's also some discrepancies in competency expectations within sterilization care. So sometimes women who are in labor might consent to a tubal, if it's usually it will be discussed beforehand, but oftentimes they'll give consent in labor. And so in this case, we can think that there's something very different being expected in terms of capacity, even within how we're offering sterilization. And so it's just these younger women who don't have children who are sort of being expected, something different is being expected of them. And I think it's too much that's being expected of them. All right, so next it's just useful to overview the professional considerations. So because we're in Canada, I'll start there. So here we just have the Canadian contraception consensus, and we've highlighted an important takeaway, which is that age parity and other practical concerns should not be a barrier to obtaining permanent contraception. So that's the SOGC, the Society of Obstetricians and Gynecologists of Canada. And so that's their official stance, that age parity and other concerns are not absolute barriers to contraception, or not contraindications. And we can see also analogies with other professional guidelines in Canada, the US, the UK, and Europe. So all of them recommend a more cautious approach to sterilization. So really ensuring that there's good informed consent, that women know what they're getting into, and that there is this well-considered request, but age and parity are not absolute contraindications. And so this is just useful to highlight, because what we're recommending is very in line with professional considerations. And we think that this, as well as the ethical discussion, point to this professional duty to really strongly consider these requests that patients are making. Okay, sorry about that. Okay, so next we have a bit on considerations for managing practice. So we have 7 in total, and I'm just going to go through them quickly, and then maybe emphasize how these relate to the ethical discussion. So our first suggestion is to establish the risks and benefits based on a patient's values and goals. So again, what we were drawing from some of the popular discussion about this, as well as some of the qualitative research, is that it seems that there's this, maybe these values or goals that the patient has are not necessarily translating in practice. And so it's important that we're thinking about what a sterilization might contribute to a patient's well-being overall in terms of her own values and goals. It's also useful to consider and explore if the patient has a reasoned request and a desire demonstrated over time. And we also recommend that a desire for sterilization should be documented, even if it's not ultimately granted. So in this case, we're not arguing that there needs to be this documentation of a patient having requested it previously. But if a patient is coming in year after year requesting sterilization, that is salient in demonstrating, that this is a deeply held value, and it has potentially a lot to offer in terms of autonomy to grant this request. So we also think it's important that personal or normative biases, do not let personal or normative biases or values affect counseling or stewardship of this procedure. So ultimately, again, not placing some value that the patient doesn't necessarily endorse for herself on her. And so it's ultimately that her values should be the one guiding the discussion. It's also important to consider that the fiduciary duty of a practitioner is to the patient and not their family members. So this is relevant when we talk about things, such as the man of your dreams quote that Nipa brought up at the beginning. In this case, it's really important that care is centered towards the patient. And so we do, of course, acknowledge that sterilization can be a part of family planning, but that really has to be done on a patient's own terms. And she is the recipient of care. And so it should be, her interests at the forefront of the discussion. So next, we think it's important to consider what elements, so regret and age, obviously, are the 2 ones we've talked about that are relevant to an informed consent discussion. So we do think it's important that a patient is informed of the risks based on her age and her parity, because this is important in terms of, thinking down the line what might occur. And so in that case, it is relevant for an informed consent discussion, but not necessarily, a barrier to care. Again, this one is really important: foster and maintain a therapeutic relationship by offering an objective and non-judgmental patient-centered space. So again, this goal of a patient being able to bring in her values to the discussion and her goals, and feeling that this is something that's going to be taken seriously in consideration. And then our final suggestion is to consider collaboration or formal consultation with a colleague, the involvement of a hospital ethicist potentially, or referral to another specialist MD if a practitioner ultimately decides that sterilization, they don't want to grant the sterilization. We think this can be helpful because what a lot of women discuss is going back year after year to request the same procedure from their family doctor, for instance. And so in this case, it might just be better to see what another professional thinks about the case. And it can help in terms of issues of access to sterilization care. So we also want to highlight perhaps the bounds of our research and also where we might go next, or where we think it's valuable to do further inquiry. And I think this also highlights, just important steps to take in terms of better understanding the issue. So it will be really valuable to have better data about the prevalence among men and young women across Canada, according to age parity and other sociodemographic factors, the access of permanent contraception, or also like potentially rates of sterilization refusal, because again, there's not great quantitative data about this. So having a better idea would be really helpful, I think, in discussing having the ethical conversation. It would also be helpful to research physician attitudes towards elective sterilizations. And then finally, approaches for considering like unique challenges with other cases among other demographics of permanent contraception. So lastly, we're just about to wrap up. So just some final thoughts on my part. The main thing that we're aiming to defend in this paper is a reflective and moderate approach in responding to these cases. So we recognize that each case is unique, and that, as well as regret and age being relevant in establishing the risks of the procedure and in having an informed consent discussion. But the main takeaway from this discussion is that when age and potential regret are treated as absolute barriers for access to permanent contraception, that they're playing a disproportionate role in decision making. So with that, I'd like to thank everyone so much for their attention. And I'm really looking forward to the Q&A and to hearing your thoughts.
All right, thank you so much. So it's now time for questions and discussion. So if you have a question, please put it into the YouTube chat. If you aren't logged on to YouTube or wish to ask a question anonymously, you may also send your question to jcb.ea@utoronto.ca. The email address has been posted in the chat for those of you who are joining via YouTube. All right, so Alyssa, Rebecca, and Nipa, thank you for a tremendously interesting talk. As questions begin to come in from the audience, I wonder if I might kick things off with an opening question. We'll call this a Kickstarter question. All right. So is it possible that denying sterilization requests preserves a patient's future autonomy, since it provides a patient with more reproductive choice in the future?
Yeah, I guess I could kick us off with that. So that's thanks for the question, Rashad. So I think I've come across this discussion before in terms of present autonomy and future autonomy. And so the most useful thing to highlight, I think, if we're thinking about it from that perspective, is that there are lots of things we have to do to live, that when we make decisions where we have to potentially limit our future autonomy, we have to sort of cut off future options. And so just having the availability of more choices in the future isn't always actually the best thing in preserving autonomy. It's more so that a person is able to reflect on in the moment and sort of make the best choice for themselves, even if we're aware that that limits choice in the future. That's the most important thing. And yeah, maybe another thing to highlight, because we focus so much on regret, there's also another way in which it works well for people. So they have their sterilization and they're, thrilled with the decision, and it works well for the rest of their life. And so we don't necessarily want to prevent someone from seeking that out for themselves just because of the risk of limiting options in the future.
Excellent. I'm not sure if Becky or Nipa want to add anything.
Yeah, I mean, even just throughout doing this research, it was very interesting to try and put yourself in the shoes of a physician and try and ask yourself, why would I value the autonomy of this person 10 years on versus this person that's right in front of me, right? The patient right in front of me. So it makes sense that they would want to think long-term consequences of treatment, but as long as someone is giving really robust, informed consent, the respect to that person in front of you, of course, should make sense that it would be prioritized, right? So that's why we take a cautious approach. We're not saying one way or the other that sterilization should always be granted. It's at the first request. We're saying that there should be a cautious and pragmatic approach where, first and foremost, the patient is respected.
Awesome. Okay, next question. So does the data on regret include trans folks who have accessed permanent contraception, or does it focus only on cis women? I'd assume the former might have lower rates of regret here.
It's a great question. From what I understand, these studies are not as current as they should be. So I know the CREST study was done in the 70s or 80s, and then the second study that we mentioned was done, I believe, in the late 90s or early 2000s. And as we might be able to sort of assume at that time, trans issues were not taken seriously or as seriously as they should have been. And so I believe at that time, the subjects, the participants in those surveys were all cis women, at least cis sort of presenting.
Yeah, and I think it's also useful to highlight perhaps maybe like where we think our research is most applicable. I think there's definitely the discussion here is definitely salient for potentially other demographics. But when we're thinking of trans people accessing permanent contraception, for instance, we might think that the values and like the potential benefits that it might provide to a patient are, like different in that they align with like these gender affirming like the importance of affirming their gender and like supporting a transition, for instance. And so in that case, it might just be that the discussion is slightly different there, just because there are other ways in which it benefits them, which are also important to consider. So we don't necessarily consider that, but I think it's, definitely important to include in the discussion.
Okay, excellent. Next question. Thank you so much for your presentation. I was surprised that one of the recommendations was for OBGYNs to refer forward. Is there no current guidance for practitioners who conscientiously object? That is a technical term, so maybe just to be fair to our audience, maybe just a very quick description of a conscientious objection too.
For sure, it's a great question. This plagues me too, this question. So a conscientious objection is something that if a clinician, it doesn't have to be a physician, experiences where they have a conflict of conscience. It's not necessarily a clinical contraindication that they are refusing care because of some clinical reason, that there's a problem in their own conscience. They feel that there's something in their own conscience and their own morality that won't allow them to go forward with the procedure. So here in this scenario, the first way I approached it a few years ago in my master's was actually through this lens, the conscientious lens. And I found that in current conscientious objection literature, it was found that it had much more to do with, of course, MAID and termination of pregnancy, and it had a lot to do with religious objections, and objections that weren't necessarily religious didn't seem to be taken seriously in the literature at that time, at least from what I found. And so when I tried to connect the dots to something like tubal sterilization, I kept running up against regret, and whether regret is a clinical contraindication to treatment or a conscientious contraindication to treatment. So even just defining that created a whole other rabbit hole. But just to answer the question directly, there aren't quite specific guidelines for tubal sterilization, but we could sort of take what we know from the MAID scene, and we know that effective referrals are necessary and they're an obligation. So the same thing can be applied here, I believe.
I'll just add another, I'll build on what Nipa has said. So I fully agree with what you've said. And I would say some people would debate whether or not the reasons that some physicians turn it down we even classify as conscientious objection. If we put that debate aside and we look at college guidelines for physicians in particular, conscientious objection, if it were to classify as that, as opposed to just certain personal attitudes or judgments, which is different than sort of a moral religious claim, one would still need to make an effective referral.
Excellent. Another question. Thanks. I like the practical recommendations. I'm wondering though whether they, especially, and then it says 3 and 6, it might be referring to one of the numbers in one of your slides, presuppose that physicians are aware of their own values. What if they're not?
And bring up 3 and 6 just to be very specific.
While you're doing that, I would say my experience, and this is, anecdotal and working in the space with the OBGYNs, I think physicians may not be, if that's a fair statement, that not just physicians, but many people may not be aware of value judgments. I think most people are aware of their values, and I would say certainly many physicians are able to at least reflect that they are or they are not comfortable. It tends to be quite polarized in practice, where we see physicians who are significantly more comfortable and then physicians who don't do it at all. And then sort of a very small group in the middle, at least would be my reflection. So I think although they may not be aware of their biases, they probably are very aware of their practices. And there's an opening there just to say, can you reflect on your current practices and then start using sort of an ethical reflective tool to say, and why is that?
Just to add, if we bring up that question again, what if you met the man of your dreams? I bring up that question all the time, but I think there's a lot within that question that can be unpacked, right? When I first saw that story, I think I must have been 24, and just hearing that question as a 24-year-old woman, I just gasped and I thought, oh my goodness, the sexism, oh my God. But then I'm also a bioethicist, right? And I thought, okay, what is this physician actually getting at here? What is this physician trying to figure out by asking this question? And so when I tried to sort of get into the brain in the most charitable way possible, I started to realize that maybe, it seemed that the physician was a woman from the City News story, and maybe she was thinking about her own experiences, right? The way that her own attitudes towards motherhood have changed over the years. Or sometimes there's, instead of paternalism, I've heard this term called maternalism, where there's paternalism happening and a certain question is being asked, but it's coming from a place where someone's trying to be more maternal. They're showing their maternal instinct by asking a question like that. So I think if the physician in question was able to really hear how that question is received by a lot of young women, maybe she might be able to understand her own biases and, maybe her own attitudes towards motherhood and feminism and being child-free. But that's why it takes a lot of discussions like this, where we could be charitable and we can be really non-judgmental towards physicians who might have exercised a little bit more of this compulsory maternity that we mentioned earlier. So it takes some of this discussion and it takes a lot of charity. So yeah, just my 2 cents.
Yeah, and I would also say it's one of the areas where more research would definitely be helpful to understand, like we said, physician attitudes towards elective sterilization. That would be really helpful in establishing like what specific values they might be incorporating in refusing a request, for instance, or like what they're considering, in refusing these requests. So.
Great. All right. Well, we have we quite naturally have a few more questions, but we're going to have to wrap it up here unless you wanted about 5 seconds each in response. But okay, so it's time to draw today's seminar to a close. And before I thank our speakers, I just have a couple of announcements to make on behalf of the Joint Center for Bioethics. So please, get your calendars out. Our next seminar will take place on Wednesday, January 18th in 2023. Information for this seminar will be announced shortly in our newsletter. And to sign up to receive our weekly email reminders about JCB seminars or to be added to the distribution list for the JCB Events Digest, please email jcb.info@utoronto.ca. And this is all going to be in the chat. CSB students enrolled in the CSB Student Seminar course, please remember to keep track of your attendance. Please don't do what I did and retroactively go back. Make sure you keep track of your attendance. And so Alyssa, Rebecca, Nipa, on behalf of all of us, thank you very much for your presentation and the insights you shared with us today.
Thank you so much.
Thanks for the opportunity.
Yeah, thank you all.